So my belief is that to limit dentists and dental hygienists to caring for the oral cavity alone is based on obsolete information in an outdated, counterproductive model of care. What we need to concentrate on is the model and doing it, getting it done. They will come. These other things that need to change, they will come. But let's just start doing it. We are going to use our practices in dentistry as an entry to wellness at the point of care. I'm going to provide the framework for people and how they can do that. And no more hypothetical, no more, oh gee whiz, if we just, it's real.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 272. My name is Andrew.
And this is Michelle. Welcome, welcome. It's sunny and spring-like here, and I am just feeling all the happy vibes.
Half of our listeners want to just swear at you right now because it's not probably the same everywhere.
I know, but it will come. It will come for you guys too. Hopefully soon.
And to rub it in, because I mean to do this, it's about 84 degrees today. So it's going to be 88 at the end of the week.
Whoa. That's something.
Yeah.
Well, welcome everybody to our podcast for dental people. And we're trying to be more inclusive, not just dental hygienists, dental people.
Everybody. Lab techs, this is for you.
And if this is new and this is your first time listening, we'd love for you to hit that subscribe button. Or if you're an avid listener and you just haven't subscribed yet, like you should do that. Click that button. And we're just going to get ahead of it and ask for some reviews. We'd love those too.
Shameless. We have no problem doing that.
Shameless.
Sounds fantastic.
So we have a really great interview today, but in the middle of it, she talks about she had some kind of program where it was like physicians and hygienists and doctors, dentists, all the likes, right? Sitting at a table and they were trying to have this real collaborative conversation. And she was saying how they loved it. They loved learning from the people in the dental industry. I'm talking about physicians and the nurses and everything. And it made me so reminiscent of my mission trips. And I want one so bad because that is all my trips have always been medical dental collaboration. Mm-hmm. It's such a little tiny microcosm. There are 40 people max on this trip. And we are riding to and from these things sometimes for an hour on a bus. And we're just learning from each other and how excited we get to be collaborating. And I'm I want it. I miss it so much.
It'll happen. I would be willing to wager that you'll be able to do one by the end of this year.
Well, now that I'm fully vaccinated.
Yeah. And they're starting to lift all of the bans and stuff from other countries. I just read another article about that if you are vaccinated, then you can go ahead and go in without quarantines. And I think there's still a large portion of the world that you can't go to. I think it's 100 countries, though, that you can go to in the U.S. or from the U.S.
Yeah. Yeah. I'm ready for it. I'm ready to get out into the world, help people, train people, get my, fill of doing something good in the world and fills my little heart and just do it.
Though, so as I don't want to step all over the episode interview, but every time we talk about medical dental integration and collaboration, I can't help but feel a little bit negative. Like we're just not doing enough. We're not trying hard enough as a world to come together to the middle. We're so siloed. As the
collective.
And, we're they're territorial and no, we're this type of doctor, so that's what we'll do. And no, we're this type of hygienist, that's what we'll do. And then we'll only do those things. And it makes me a little bit sad.
Well, she does mention how a lot of the stuff, we really need to see a change in our education. And I think this goes back to a ranting blog that I wrote the beginning of last year, talking about there's got to be more to dental hygiene than this, and how it all started because a lot of the magazines were you just want to clock in and out, go be a dental hygienist. And I was I will murder you. Stop telling the world that. Or 8 hands-on jobs that you can leave after you clock out or some nonsense title like that. And I was like, no, like we need to be telling people when they go into dental hygiene and dentistry in general, that there's a change. Like we are trying to be bigger than just a scaler or a drill in our hand. And there's a bigger message. And I think that needs to start before they even enter the program. Like, who is dentistry? What are we trying to do? We're tired of chasing disease, and then hopefully setting the stage for, as a collective, like not for doing more. I don't know if I'm making sense because I'm definitely working this thought process out in my head as I say it, but it has to start before they get into school. It has to be a continued message, even just being taught to like, how do you cross that barrier to the medical world as a student? And then how do you keep that going in an industry that's probably, and I'm talking about our dental industry, is like going to fight against that just a little bit.
Yeah. Well, and the thing I also like about that though, is if you want to jump into the fight and be like a Michelle who like doesn't care about anything, she already said she's going to murder people on this exact episode. So you know that she has no shame about doing all of that. Or the opposite end of the spectrum is starting off with surveys, participation in data collection, doing the right thing at your office level. Casey kind of goes into several things that we can do to participate in this bigger thing. So I guess there is more that is available to us than kind of like my little negative rant just a minute ago.
Well, and I also think like something so small could just be taking really amazing notes, chart notes, and telling your patient, like, these are the things I'm seeing. If you're, bring it up with your primary care physician, and I'm happy to send them these notes so they know our findings. They know what we're concerned about. Literally, that's all just take really good notes, acknowledge what you're finding with your patient, document it, and just say, hey, these are available if they are interested in reading them. We highly encourage this. We want to be a part of this journey with you. So bring this up with your primary care physician. Well, our interview today is really fantastic with Casey Hein. I'm just really happy to have this conversation, and we would love feedback from you guys too. If you're doing any kind of medical dental integration already in your practice, if you have ideas, like let's talk about it and really kind of start this journey and do better. Just do better in it. So enjoy this episode with Casey Hein.
Before we get to the interview, we want to say a big thank you to Paradise Dental Technologies, or PDT, for supporting the continuing education portion of this podcast for so many years. If you do not know already, many of our full-length episodes count for CE. You'll find the links in the show notes, or you can sign up for our newsletter by going to atailotohygienist.com. When you sign up for the newsletter, we will periodically send out links to shows that have expiring CE courses attached. And none of this could be possible without the support of the amazing people over at PDT. So check out their hygiene and other instruments at pdtdental.com. That's pdtdental.com. Now, on to the interview.
All right, listeners, I am really excited to introduce you to today's guest. I have been enjoying Casey's articles and following some of her content because I do feel like it, even though it feels a bit progressive, it should be the now. And so I'm excited to talk about it today. So welcome to the podcast, Casey. Casey Hein, I should say. I'll give you your last name.
Thank you, Andrew, for inviting me.
So Casey, I would love to just hear a little bit about who you are and your journey in our dental profession.
Oh, wow. So I don't even know where to start. I probably am the oldest person still in the profession of dental hygiene. So I've been around for about 100 years, and I've had the advantage because I have been around for, I was totaling it up the other day, and if I count when I was a dental assistant in high school, it's 50 years of dentistry.
Wow.
I've worked as an academic, as a clinical professor in periodontics. I've worked a lot in private practice, in public health. I've worked on the business side in initial public and doing the due diligence for initial public offerings for DSOs. I have worked with industry, government, and I had a clinical practice for many years that was really successful, and it was concentrated on periodontics. And I launched the first journal on oral systemic medicine called Grand Rounds in Oral Systemic Health, and wrote the first curriculum for physicians and nurses about the significance of oral health. And so I've done it a whole lot. Yeah. It's just been a really interesting journey. So the last 15 years of my life, I've spent trying to educate physicians and nurses. We call them non-dental healthcare providers. And that also includes social workers, diabetes educators, pharmacists, et cetera. You get the point. And the significance of oral health and looking in the mouth. And a lot of my work has been done at the University of Manitoba. I actually convinced the provincial government of Manitoba to fund about $500,000 in this curriculum project to educate physicians and nurses about this. And it's not just this project, but it's also other initiatives done by authorities such as the American Association of Medical Colleges, ADIA. And basically what we've seen over the beginning about 5 years ago, is that physicians and nurses have really stepped up now to do a lot of things in the oral cavity. They get it. They get how important it is to look in the oral cavity and train them how to look for early childhood caries, look for oral cancer, and to screen for periodontal disease, the three most prominent dental diseases. And they're doing things like administering fluoride treatment to children. I know in the subarctic areas of Manitoba, we actually train nurses in nursing stations because there are no dentists there to actually put in drains in mouth to drain infections. So here's where I'm going with this. The reality of it is they are on board. They totally get it. If you look at the amount of research that has been done in some of the most prestigious medical journals in the world on things like periodontitis and systemic diseases, it is amazing. So now the real issue at hand is our inability to look beyond the tonsils and connect the dots between the area I'm going to address today, because it's my area, is periodontal disease, but there's other oral systemic interrelationships. So my belief is that to limit dentists and dental hygienists to caring for the oral cavity alone is based on obsolete information in an outdated, counterproductive model of care. What I mean by that, briefly, is that we were trained that it was all about oral hygiene, right? And keeping the mouth clean. Well, the most recent, over recent years, there's been quite a bit of research out that plaque doesn't tell the whole story. There are other factors, other risk factors that play a big role, and some of them are modifiable, like smoking and poorly controlled diabetes. Some are non-modifiable, but we have to. So it's been suggested that only 20% of the risk for periodontitis is associated with plaque. The balance of it, the 80%, is from modifiable risk factors that include genetic, environmental, et cetera, et cetera. So we have to take this into consideration. And I truly believe that the new guidelines, I hesitate to call them new because they were they were written in 2017 and published in 2018 for classification of periodontal diseases. I'm really so excited about that because it is the first time that we have guidelines that incorporate factors outside the oral cavity. So we have to start thinking critically about these things. So it really does go hand in hand with this thought that I have that we need to move beyond this obsolete stuff that we learned in the past. So it's about erasing and relearning a lot of what we learned. So yeah, that's probably more information than you wanted, Michelle.
No, definitely not. And I'm excited to get into it, but I do have a question because in some of my presentations, I also give some I don't feel like it's new thoughts and theories around how to, approach patients, but it's definitely different than what we are taught in school, right? In our education and our training. What is usually the response, the feedback, pushback, even from an audience when you talk to them about a topic like this, like really starting to think about not just the oral systemic, but like how we actually approach our patients during our own patient care?
All right. So what you're describing is this concept of dental or dental medical, however you want to put that, integration. Some people have different definitions of that. My definition is that we educate and train oral healthcare providers in every practice about this, that it's not really a specialization, that it really is, it may be top of licensure. It needs to be a standard, not necessarily a specialty type of thing. I think we have to move there. And so my response to your question about how well it's received is this. I think that when people, I just presented at the Chicago Midwinter a couple of weeks ago, and what I found there and other places is when people choose to come to my courses about this, I think in many respects, I may be preaching to the choir. They're already thinking about this. Yeah. And so they're early, I call them early adopters, right?
Yeah.
They may be there, they may be thinking about it, but they don't know how. First of all, we don't know really what that means. So one of the things I'd like to talk about before we finish today is a pretty massive survey that I'm sending out with the help of media partners to actually query oral healthcare providers about their attitudes and preparedness for this. What are you doing now, et cetera? And, I think in many respects, I've been preaching to the choir. In other programs I've given, there have been a tremendous amount of people that have come to these. And so I get a ton of email afterwards. This is just beginning. We don't have it all figured out. All I'm doing is asking the questions. I have a few ideas on how we can make this happen, but it's morphing. And I need everybody to weigh in on this, because the truth is we're swimming around in this together. It's new. And so it can be what we want it to be. But what I am clearly saying is that the way we're doing it now in dentistry, it is completely obsolete. That doesn't mean that dental hygienists will not be performing prophylaxis and treating periodontal disease. Of course we will. We'll still do all those things. But in addition to that, we're going to be looking holistically. We have to. It's not, a nice to have, or if we have time to do it, we have to do it. That's all there is to it. So that's really a function of how much evidence we have now of periodontal systemic links. Everybody knows about periodontal systemic links, Michelle and Andrew. It's just, that's kind of, I'm not going to say it's old news, but the awareness of it is great. Now, what are we going to do with it? It's one thing to acknowledge it, but it's a whole different thing to implement that knowledge base.
So let's get into it. Let's talk about, how do we do this? How do we integrate and not be obsolete?
Yeah. So along those lines, I just want to share that what I'm advocating for here is part of a continuum that started a long time ago. Do you realize, Michelle, it was 1945 when somebody by the name of Belding published the first article on why it was a good idea to do blood pressure readings in the dental office. And that
blows my mind.
1945, right? And
there are people still not doing it.
I know it, right? That's a whole different conversation, sweetheart.
Oh, goodness. And we're on the closer edge of 100 years since this was posted.
I know, right? And so 20 years later, it took 20 years, but 20 years later, another author by the name of Abby wrote another article in Journal of American Dental Association about screening for hypertension. And it was at that time that the ADA really got on board with this and urged members to participate in the national high blood pressure initiative. And so that's when it became a standard of care. Ironically, that's the year that I graduated from with my baccalaureate degree. Yeah, so that became a standard of care in 1974. So do the math on that. Okay, and here's it to bring it full circle here. A lot of time passed, as I see it, before there was any new addition to this continuum. But in 2018 and in 2019, the American Dental Association approved 2 CDT codes for doing blood glucose testing in chairside in practice. So we can bill for it. It's just many insurance companies are reimbursing for that. There's many reasons why we want to do that, which we don't have time to go into today. But it's phenomenal. But the fact of the matter is that decision the ADA made, what didn't come out of the blue for them, it was actually predicated on the fact that many practices that were innovators who were really willing to take the risk just did it, even though they weren't reimbursed, even before those mechanisms were in place. They just started doing it for good reason. And so, the ADA, and it was a couple of universities that got involved that urged the ADA to start to consider coming up with a code for those things. So now it's part of all this. More recently, starting last year with COVID-19, dentists are many of them now in its various states actually giving COVID-19 vaccinations. What I'm saying here is this is not a new concept. So if somebody says to me, well, Casey, that's not in the scope of practice. Well, it's not, but this is not really new. It's part of a continuum. So one of the things that is a challenge for us is how we get there. How do we move from where we are today to this model of care that I call the non-physician primary care model of care? And so one thing that the research I've done over the years looking at this is looking at the mind lines, meaning what influences the way we practice. There's been quite a bit written about the mind lines of physicians. We don't have that information on the dental side yet, but the research I've read suggests that the number one influence that we have in the way we practice is how we were educated, pre-licensure education. And I think that most people, if they think about it, they would probably agree with that. And here's the reality of the situation. If we look at the companies, let's just say dental hygiene. I'm not going to go into dentistry. I don't know them as well, but the dental hygiene competencies I'm pretty familiar with. If we look at those, there is nothing in there about systemic health, or it's very diluted. So we really do have and of course, the way we are educated is based on those competencies. So we do have our work cut out for us.
I'll tell you, I've never heard mind lines before, and I'm going to sit with that. Like, I think that is a very big concept that I have not put together before. Mind lines.
Yeah.
I think also, I know we're kind of moving past this influence thing, but influence just in general is almost never really talked about. I don't think that's studied. I don't think it's discussed. I don't think that me as an individual clinician is maybe really thinking about what is influencing my decision making. And we're just going through this life and we just do the things that we do. And we don't think about why we're doing them. So as
the biases that are so indoctrinated
exactly.
that we just don't think about. But this is fascinating. That's a term that I've not heard. And I think about it from a social construct, like all these things, but not really from our licensure and our education, even though when I say it out loud, I'm like, oh, obviously.
Right. So you guys are both so right on. I'd like to challenge you to think about something. What happens to you when the evidence doesn't really fit into your belief system or the way you do things?
I think we both have very different ways of doing that.
Can we answer this though, like right now? Because I would love to hear Michelle's answer to this. Like, what happens when the evidence doesn't fit for you?
I definitely challenge it.
Things, and the way you practice, what happens?
I definitely challenge it. Then I challenge it. I sit in the icky feeling, that dissonance that I immediately feel when it's going against something that I knew to be true. or thought that what I was doing was right. But then I go into the next level of like becoming slightly obsessed with finding out the what's behind it. Like, what's the driver behind that? Am I doing this wrong? And then I kind of work through my ickiness and then I apply it.
That sounds
That's
about
good.
right. Yeah.
Yeah, that's right.
I
Andrew,
think
how about you?
I'm a little bit different. I think, I mean, not too different, I don't think, but I rely a lot on kind of like my feelings and interpretations of things. And I am am I doing harm or am I doing good kind of assessment right away. And I think I'm a little bit more okay with doing things that I don't necessarily have the evidence, as long as I'm feeling good about the outcomes or the things that I'm seeing like visually.
Those are great answers. And I think a lot of people will identify with them. The big gap here is the challenge we face with taking this body of evidence of oral systemic interrelationships and taking it and implementing it, and coming from, as an educator in a big university and writing a curriculum to teach dentists or physicians and nurses about oral health. It is monumental to try to change the way people are educated. It is just so difficult, and here we're faced right now with an escalating shortage of dental educators. And it's just tough. Who's going to do that? Who's going to do that heavy lifting to really change this? So one of the things I say all the time is, don't worry about that right now. Don't worry about how we're going to get paid for these other procedures. Don't worry about scopes of practice and state practice acts. Don't worry about any of this. That's going to come. What we need to concentrate on is the model and doing it, getting it done. They will come. These other things that need to change, they will come. But let's just start doing it. And so one of the models that I really urge people to consider is what I consider the Holy Grail. It is the perfect model for medical dental integration, and that is periodontitis's inflammatory threat to organs distant to the oral cavity. And so, so we know that there are kidneys, we know that there's pancreas, there's lungs, there's heart, there's the developing embryo, there's brain, there's the skeletal system, GI tract. All these organs they're remote to the oral cavity, but we know that periodontal infection is not confined to the oral cavity. But we know that periodontitis poses a huge threat, inflammatory threat to these other organs. It provides for us a very strong rationale for why we need to look beyond the oral cavity. So I'd like to introduce this concept called transdisciplinary care. What I mean by that is, if we consider all those organs that are associated with periodontitis, that there is this junction between medicine and dentistry. And the truth of the matter is, we will share responsibility and accountability for patient outcomes. And let me give you an example of what I mean here. Let's just say, for instance, there's a woman who has experienced preeclampsia that is problematic, that there are some adverse pregnancies outcome associated with her preeclampsia, right? If she has untreated periodontitis, or it's treated but not managed, not controlled, we have joint responsibility and accountability for that patient outcome. It's not just the obstetrician. That's where we are today. What do you guys think about that?
I think it's amazing. I personally practice with the concept that I have the right to refer people to, their physician. Let's talk about vitamin D levels. Let's talk about airway, sleep. I disclose every one of my patients. And when I talk about the deep blue bacteria that's been there for more than 48 hours, I talk about its connection to oral systemic health. I, however, feel that I get stuck because I don't have the support of the team to push that patient to go to their physician or my local. And granted, I feel like if I was more full-time private practice with this one particular office, that I would make the initiative to go around to the doctors that my patients are seeing and have that discussion with them and be a little bit more proactive. So that's definitely on me and my lack of being in it on a regular basis. But I just, sometimes I feel like I get excited about this information and then I find myself stuck. And knowing that there's more, there's something else that I could be doing. There's something that the patient needs to be going to do, and there's not follow through. And that brings me a ton of anxiety. So it's almost like the more I know, the more I apply, but I get more anxiety.
No, I totally get it. And again, we go back to the reality that it's one thing we know these things now, right? And now we've got to implement them. And that's where it kind of gets fuzzy. So I am actually reimagining my own business. And what I'm going to be doing is actually putting up a subscription-based, very inexpensive type of campus for people to come in and take courses specifically. They're simple ways that we're going to move forward with this model. We are going to use our practices in dentistry as an entry to wellness at the point of care. I'm going to provide the framework for people and how they can do that. And no more hypothetical, no more, oh, gee whiz, if we just, it's real. It's very real. So I expect to have this done in probably by the end of the summer. So I would love for you guys to get the word out for me on that.
Yeah, absolutely.
Yeah, but see, I truly do believe that this model called entry to wellness at the point of care, this is not just for dentistry. Let me give you an example. Pharmacy. So it's the point of care wherever a patient happens to connect. If it's with the pharmacist, who says to a patient that has poorly controlled diabetes, if this pharmacist says, Mrs. Smith, when is the last time you had your HbA1c tested? And Mrs. Smith says, oh, you know what? It's been a long time, like maybe a year or so. That's a point of entry to wellness at the pharmacist. And it could be the diabetes educator. It could be the social worker. Okay. So it's about entering healthcare wherever that patient could be. And we need to be part of that. And we cannot back away from this. It's so very important. And I just think that it's time. And so some of the things I'm talking about here, we can identify people. Now, again, we're not diagnosing, we're screening. There's a big, we all know that difference. And I'm not advocating for diagnosing. I'm advocating for screening. And so in doing that, we can identify people who are not aware that they have a disease or risk factors for various diseases and conditions, and people who need to be educated on risk factor reduction, how they can reduce their risk for many of these inflammatory driven chronic disease states. We can identify people who are not complying with physician recommendations. That includes medication regimens. It includes lifestyle modification recommendations. Another example is people who are not up to date on immunizations and various screenings that are recommended during various life stages or routine medical tests. Screening for non-communicable diseases. The big ones are cardiovascular disease. Diabetes is the low-hanging fruit. We have got hypertension, osteoporosis, cancer, chronic respiratory conditions. That's what you mentioned. And how about infectious diseases? That includes COVID-19, human immunodeficiency virus or HIV, the human papillomavirus, HPV, hepatitis C, herpes simplex, and chlamydia, believe it or not, and gonorrhea. We can do that. And yeast infection. And that's just part of it. Other conditions would be things like potential for adverse pregnancy interactions, nutritional deficiencies, like you mentioned, Michelle, depression. That's a big one right now, right? We are so well positioned for that. And there's a very easy way to do that. Just ask two simple questions. Obesity, child and elder abuse, and substance abuse. I mean, the list goes on and on. And I'm sure for those who are listening, they're going to think of a million other things. Well, maybe not a million, but there's other things. And so talking and actually doing biometric measurements, body waist, body mass index, waist to hip circumference. I know that may sound weird to a lot of people, but it's time for us to do that. And here's an example, real quick. I want to share this with you. So let's think about this as an example, and then I'm going to stop talking. So today, they're estimating that about 34.2 million Americans have diabetes. That might be a little higher right now, but in the newest data, or let's say 10.5% of the population. Only 21% of them are diagnosed, treated, and controlled.
Really?
Yep.
That seems so low to me.
Yep. Very low. So let's just say, let's round it out to 20%. There's 80% that are in our catchment. They're people, I call it catchment area. So these are people that come into our office. So 80% are either diagnosed but not treated, diagnosed, treated, but uncontrolled, and 25% that are totally undiagnosed. So how does that play out? Let's look at those numbers real quick. This is what I consider the diabetes catchment in dentistry. So this assumes, and I use this as a metric. So it's a single dentist with two dental hygienists. That's the units that I'm talking about here. So a solo dental practice that consists of 1,500 active patients. That is what the approximation is. We're going to say 300 of them are kids. So there's 1,200 adults. And if we look at 10.5%, which is the estimate for people with diabetes, that's 126 patients in our catchment area. And this is how this plays out. There are going to be 32 people in the practice with undiagnosed diabetes. There's going to be 57 people that have been diagnosed and treated, but not controlled, and 11 people who are aware of diabetes, but they're not treated at all. That's a lot of people, 126
a lot of people.
patients. And so I'm just overlaying those statistics, and I'll tell you one of the things that make this so important to us is this new data that's come out. It's called the Rising Risk Populations. And they're populations with rising risk as a consequence of the lack or deferment of medical care during the COVID pandemic.
Makes sense. Yeah.
They reported that about 1 in 5 U.S. adults have reported that there's household members that have been unable to get or experience delay getting medical care for serious conditions. And among those that reported delayed care, 57% reported negative health consequences as a result. And most of them, by far, the lion's share, cited that it had nothing to do with financial barriers. So what does that mean to us? It means, hey, they are going to come see the dentist and dental hygienist, but they may not go in to see their medical providers because many institutions are just overwhelmed.
Right.
And what's worse is we see this massive exodus of physicians and nurses that are just so burned out. So, yeah, we have a huge role to play.
My brain immediately goes to the treated and uncontrolled because, gosh, if we see that all the time, don't we? That's what I see the most. Like, I can't control their perio. I can't control the inflammation in their mouth, and they're, overweight. They're struggling. There's sleep. There's so many things that I'm like, oh, and that's a huge number. Like, so that for me, that empowers me that I can affect such a giant number in my practice.
Yeah. And we just need to get comfortable and not be afraid to talk to medical providers. Jump in And the research I've done, actually, I've done some programs, big programs at University of Manitoba. We had an oral systemic health day, and it was interprofessional. So we invited physicians, nurses, dentists, dental hygienists, pharmacists, social workers, on and on and on and on to this to talk about oral systemic health. And there were probably, 500 or more people there. And we had an opportunity to divide into work groups that were totally interprofessional. So the physicians weren't allowed to all sit together, et cetera. These were working lunches. So we had dentists and physicians and hygienists, et cetera, all of them different at each table. And it was all case-based learning. But I will tell you what came out of that is this. Physicians said, I never knew how important it was to look in the oral cavity. And I am so excited and thrilled about working with the dental team, with hygienists and dentists. And please, we want to collaborate with you. So we should not be bashful about this at all. We just need to become really comfortable with this knowledge base. For instance, on diabetes, what does an HbA1c mean? Why is it important? How do we interpret the results, and how does it apply to our treatment plans? And how do we talk to our cohorts on the medical side? So all those things, right? And yes, we just need to get comfortable with that. Andrew, what say you?
I have lots of questions, but I want to kind of change topics if we can a little bit.
Sure.
I want to go back to the beginning. So here's what I'm hearing from kind of what you're saying. It's really important to have all of these touch points across every aspect of medical care. Our pharmacists, our dental teams, our nurses, our personal care physicians, all of those people. But at the base of all of this, the giant majority of everyone listening is a dental hygienist. And I would like to know, how do we get employers, how do we get companies that we work for to see the value in what we do? Because I feel like, from what we talked about before, our educational systems being the largest influence have trained dentists and hygienists to go in and be basically mechanics. We go in and do the scraping of the tooth.
Disease chasers.
Yeah. So how do we get employers to see the value of it so that we can now have that maybe a little extra time or whatever to do the right thing?
So I will tell you this, Andrew and Michelle, from the point of view of treating periodontal disease, that I can speak to specifically here. There have been some incredible cost-benefit analyses done on this that have shown a dramatic reduction in cost of taking care of people who have chronic inflammatory diseases such as coronary heart disease and diabetes and cerebrovascular disease. That there have been studies about treating women, pregnant women, and reducing the cost of care. And so much so that the government has really looked at that model. And that's why we can expect to see that there's going to be increased benefits on the Medicare and Medicaid side. And we can expect to see that. And but this is not just this. Insurance companies are getting on board. What we need to do is proof of concept. And so I'm going to be offering a proof of concept protocols to DSOs here pretty soon. This and the low-hanging fruit for me is going to be diabetes, screening for diabetes. And whether you do it by an interview or the American Diabetes Association questionnaire, or you do it by fingerstick technologies, point of care testing, doesn't matter. So what we need to be able to do is proof of concept. So those cost-benefit studies have been emerging for many years now. That's why there's interest in this. And, I truly believe that this movement that the American Dental Association actually provided 2 CDT codes for glucose testing chairside is just an example. And practitioners are being reimbursed for those things. So it's coming. It's coming. The research that I've done in the literature review that I have conducted, what I have found is that acceptance of this model has been very high also among physicians. And they say, bring it. We need all the help we can get. What the insurance companies are saying is, it's interesting, this is good, and we may very well get behind it, but we need proof of concept. Dentists are saying, I'm really interested, but I want to be paid for it. And I think that, there's no wrong answer here. However, I will say to those who insist on getting paid for it, that those who jump in and start doing this, they're going to be the early adopters, are the practices that stand the most to gain. Those early adopters will be the beneficiaries of patients from physicians, and patients that are really impressed with their knowledge base are going to say, wow, this is cool. This is awesome. You really, you're into this this is truly holistic health. And I'm on, and I'm going to tell my friends to come see you too, because that is the model. I was talking to a website developer that has a lot of clients that are dentists, dental practices. And this was, I want to say, about a year ago. And he said to me, we have a template for dental practices and it changes, but one thing that's constant is everybody wants us to put something in their website on their banner or their homepage about, we are into holistic health, and we know that the mouth is connected to the rest of the body, and therefore we are all about this. And he said, I'd be really curious to find out how many practices are really executing that, or really have evidence of that in their practice. Mm-hmm. So I thought it was interesting. And I just did this really rudimentary survey. I went across the country and picked about 20 practices from east to west, and big practices, good practices, right? And that looked like they, were doing well. So yeah, they had that up. And then when I actually went into their services and proceed, what we provide, there was nothing that would indicate that they are doing anything remotely to reconnect the mouth and the body. So everybody's talking about it, but nobody's doing it.
No one's doing it. Mm-hmm. As I hear you talk about proof of concept, to me, some of the low-hanging fruit for us is like, and if we use this qualifier of just hygienist and just doing basic stuff, right? Code it properly. Like, that's a proof of concept. If you're starting to code perio, if you're starting to do code what you're doing correctly, because I think a little bit of the lack of proof of concept that we have such severe oral disease in our world is because we call it all damn prophy.
I know it.
So what an easy proof of concept. Just start coding it what it is so that we can gather proper data and show that we could be treating this, we're having to treat disease.
And along with all of what we've spoken of this morning is always going to be the question about how do we implement this in the tight schedules that we have? Is this pie in the sky stuff, or can we really do it? So there's a number of suggestions that I have, but I'm going to have to hold those for another day. But one of them is something that I did many years, it was probably 7 years ago. I had heard over and over and over again from audiences is just give us a script. Just tell us what we're supposed to say that has scientific evidence to back it up about all these periodontal systemic links, so we get it right. And I was resistant to that for many years. It's no, I'm not going to tell you what to say. You need to understand it, and put it in your own words. But I discovered that it wasn't just that, but it's also time in the operatory, right? We want to make sure we maximize production. So I decided to hire an animator to do what I call mini messages. They're 60 to 90 second animations, individual, that talks about the link between diabetes and periodontitis. Another one is cardiovascular disease and periodontitis. And it's just cut to the chase. And they are to be downloaded and put on either an iPad, and you hand it to your patient to review it while you're doing something else. or you put it on your monitor in the reception area. Anyway, I just would encourage your listeners to go to my website, look under resources and many messages, and you'll see you can just download them directly. And those have been extremely well received in the community as a way of getting patients familiar with this.
I love that.
No, that's great. And it's CaseyHein.com just for everybody. And we will have that in the show notes so that you can find it. So if you're driving, you don't have to take out a pen and paper right now. It's in our show notes.
So just one other thing I will mention, two other things, actually, three other things. So real quick, in terms of the next steps. So I want to hear the thoughts of everybody about this. So I'll be launching a survey to discover what dentists, dental hygienists, and dental assistants think about performing medical testing in dentistry. And so if you're interested in this, Michelle and Andrew, I'd like to give you the link to the survey so your people can have that. It will be out in about a week. That's one thing. The other thing is this summer at RDH Under One Roof, I'm going to be doing a mega session the first day. At the end of the day, the mega session from 3 to 5. And the title of the course is Great Expectations, Our Future as Essential Members of the Primary Healthcare Team. And in this, I'm going to be laying out a vision for what this could be for us in dental hygiene, what it could look like, I think. And so I would love to have everybody there. It's not my idea alone. We have a lot of work to do, and I want everybody's input. And lastly, there's another program that I've been asked to deliver a TED Talk type of thing to. There's a very big program going on this fall, and I'd be happy to share more information when I don't know whether the location will be Phoenix or someplace in Florida, but it is the integration of medicine and dentistry. So this is being produced hosted by Dr. Mark Cooper. Shine is a producer of it, and it's bringing together everybody. Stakeholders from all different places, DSOs, academia, government, associations, dental, the American Dental Association, everybody, to talk about what this could look like. And so I'd be happy. And so I've been asked to specifically talk about point of care technologies and the vision for what this could mean for dental hygienists. So that would be another opportunity to get involved.
Well, we're really excited that you were able to come on and chat with us for a little bit and kind of things. I think anybody who listens to this podcast is probably like somebody that walked into your audience. They are people who are probably like, yes, I felt it. I know I've needed to do this. I knew I was a champion for patients in a way that I didn't understand just yet. And I think that they will take this and run, because anybody who's going to listen to a dental hygiene podcast is probably the more elite clinician out there. And I love that you brought up the oral healthcare provider and how, we are the center. Like, we are such an integral part of healthcare. And it's just, we got to take these little baby steps and just get started. Just do something.
Yeah, we got to do something. And that is really the essence of what I'm going to be doing with this series of courses. And so it's going to be online courses that people can take anytime, but it's also going to be a series of mastermind groups, a lot of them. And I thank you for the opportunity to come before your listeners, your audience today, because it's just another way of getting the word out. And I also want to thank you guys specifically for being such progressive leaders. And the stuff you're doing is amazing. And I am really honored that you asked me here today.
Thanks,
I'm not
Casey.
crying.
Thanks.
Thank you. No, thank you very much. But we definitely know that we walk, or we're held up on the shoulders of giants. How's that go? Something like that. Because you guys come on and you teach us these amazing things. And we're just honored to be able to be a vehicle to get it into the ears of clinicians who are really excited to do something with it.
For sure.
Thank you, guys.
Well, thank you. And everybody go over to Casey's website, caseyhine.com. And if you are ever lucky enough to be in her audience, definitely don't sleep on that. Get in there and listen to her in person, read all her articles. And we would love to hear your feedback. If you've done some things, some suggestions, or you've already integrated this into your program, into your clinical care, we would just love to hear that.
Me on that. Casey at caseyhine.com. I would love that.
Yeah, that's awesome. Well, thank you again, Casey.
Thank you, Casey.
Thank you.
Well, another great week, another great episode. We thank you all so much for listening each week. If you haven't already, hit that subscribe button, whatever podcasting app you're using. Also, just a reminder, our guests are so fantastic that they love when you reach out. They love when you interact with them on social media. And you can interact with us on social media as well at Instagram or Facebook. We're also on LinkedIn. You can find us at A Tale of Two Hygienists. You can also go to our website, ataleoftwohygienists.com. And we would love for you to go there and subscribe for our newsletter. We have lots of stuff on our website. We have a learning center. You can search for any episode. This is an easy place for you to find the links for our CE courses and take the test. There's just so much more there. So head over to ataleoftwohygienists.com. And if you want, you can also send us an email. I'm Michelle at ataleoftwohygienists.com. And then there's Andrew, who is Andrew at ataleoftwohygienists.com. And we just want to say thank you so much. If you love this episode and you're loving the podcast, we would love for you to subscribe and leave us a review. And, 5-star, go ahead and do it. 5-star, just hit that 5-star and then leave us a review. We really appreciate it. We love reading them. It fuels our fire. And we just appreciate you guys so much. I think that's it, Andrew. Anything else?
Nope, that's it. Have a good week, everybody.
Bye, y'all.